Thank you for joining us for the fourth module of our presentations. This is going to be a case discussion module where we will discuss some cases that I hope will bring some practical aspects to the management of psoriatic disease that will tie together a lot of what we've talked about in the first three modules. So let's jump right in. And I'm going to ask Dr. Marola to keep primarily his dermatology hat on for these case discussions. And the three of us will go back and forth on several issues. All right, so the first case, I just want to say that this case was submitted by a dermatologist, and let's take a look. So this is a 41-year-old male, history of psoriasis for about 11 years, family history of psoriasis and psoriatic arthritis in his mother, first-degree relative. Psoriasis is mild initially, 1 to 2% body surface area, but he begins to develop morning stiffness that lasts 30 minutes and lower back pain that he attributed to getting older at age 41. Pain and swelling of 2 fingers in his left hand, pitting and onycholysis of his nails, and he's starting to feel a little bit more fatigued. So let's just briefly stop there. And Joe, what should dermatologists be thinking when they see that this patient has nail disease and this strong family history of psoriatic arthritis?
Yeah, so I'll make maybe 2 points. As an aside, the calling the psoriasis mild purely on body surface area, we have to be careful about. Remember to always ask the patient about how much it's bothering them. If that 1% is on their face, it's going to be pretty significant. Just as an aside. But to your question, there are a couple things here. With the derm hat on, hopefully I'm picking up on. I want to say the patient is not necessarily likely to just walk in my office and tell me about his morning stiffness and his low back pain. He may not even think that it's the right place to be bringing that up. So we have to be soliciting that and make sure that he, is asked about it. Once I hear that, the stiffness is certainly, a red flag. The family history of psoriatic arthritis is a major red flag to me. I know that increases the risk of developing psoriatic arthritis tremendously. And then the nail disease, Evan, as you mentioned in the first module, is again a increased risk for developing psoriatic arthritis. And so those things together, I think, would be tip-offs. Now, he already has pain and swelling in his fingers. I'm guessing you both are worried about that, as well as the fatigue. But so my radar is certainly up here, and I see lots of red flags.
So I do want to just mention really briefly that I think one of the hardest things for me to teach fellows is this low back pain issue. So I think in a 40-year-old, it's easy to note that, back pain is the number one, sort of complaint for internal medicine. But I think inflammatory back pain, which is what we're most concerned about, is one of the hardest things to teach. I think it's, nuanced and, trying to get that history is tough. And I think it's always important, when we're talking about cases to dermatologists or even orthopedists, is to really understand that, inflammatory back pain, that presents with morning stiffness, wakes you up at the second half of the night, sort of insidious onset, alternating buttock pain, things like that. So.
Yeah, I think as specialists, we all have the obligation to get that word out to primary care docs too, with low back pain being probably one of the most common presenting features to a primary care physician, and even to physical therapists, so that that flag can be raised in these younger patients who have inflammatory type back pain. Elaine, so this patient has hyperlipidemia, obesity, hypertension. How worried are we about cardiovascular risk in this 41-year-old with psoriasis and PsA? You told us that mortality in PsA is directly correlated to cardiovascular risk. How aggressively should we be screening? You even told us about carotid intimal thickness. What should we be doing to make sure that this patient is okay?
So as you can see with all the risk factors, this is a cardiology dream, right? So he's got all these traditional risk factors that are elevated. And the question is, who should be screening, how often, and when? So these are all really good questions. I think as long as we are alert as rheumatologists, dermatologists, it would be really helpful. Many people will do this differently, whether they'll start screening preliminary for cardiac risk factors. So, having dyslipidemia, weight, blood pressure checks is important. And then the wellness initiatives that I spoke about in terms of decreasing bad habits, lifestyle habits. A lot of people then refer to cardiology for a more formal evaluation of these risk factors, as long as we pick up on it first, educate the patient, and refer. Whether or not we may be comfortable starting a statin is going to be a little bit more individualized between practitioners, how you run your practice as well. But the AAH guidelines do recommend that after the age of 25 that we do check, lipid profile, check your weight and blood pressure.
All right, great. So, and then, so really, even before we start thinking about therapeutic options, medications that we're going to start putting this patient on, we really want to think about some lifestyle changes for this patient. What about depression? You talked about depression as a major issue. How do we screen for that? And is depression even something that's just situational in a patient like this, or could it be that cytokines related to the underlying psoriatic arthritis and psoriasis are actually playing a role?
So just to remind you that we have really good studies showing that there is an increased risk of depression, including major depression in patients with psoriasis and psoriatic arthritis. So that alone should stimulate or encourage people to screen. Many of us have been trained to look at nonverbal cues, during our visits that heightens our awareness, ask questions about that. In our particular practice, we do a little more formalized. We do have provide the patient-reported outcomes, especially the PHQ-9, that we do check upon patient check-in, which is a screening for depression. So there's many ways that we can do it, but I think the most important is just to have that in our head when we're seeing patients, and they may not be responding, or they may not be taking the education the way you want it. You might want to think if there's some mental health issues, and that can range not just from depression, but anxiety, over excessive worrying, different mental factors that can really prevent people from understanding their disease and understanding our communication with it, which we know is one of the first steps, and also including health literacy as well.
All right. And the cytokine issue, any thoughts on that?
Yeah, those are so interesting now. We have studies where we are really looking at specific cytokine levels that they may be some sort of merged pathway. So that you have a hyper inflammatory response, a low-grade inflammatory response that can occur even despite being treated for psoriasis and psoriatic arthritis. And we now know that there's some increase in cytokines in patients that are, in our major depressive issue. And the question is whether or not, we can actually lower that with some of our treatment, and whether there might be a combined effect of having, uncontrolled disease and worsening mental illness. We also know that we are, looking at gene expression data showing that certain lifestyle changes such as meditation, relaxation techniques, stress management can actually tweak that gene expression profile, making it more favorable profile if you are able to, sort of de-stress in what we know in our society. So a lot of interesting data to come.
Yeah, fantastic. Really a story still being written. All right, let's go on. Initially, his mild psoriasis was controlled with topical steroids prescribed initially by his primary care physician. When the patient developed arthritic symptoms, his primary care physician attributed this just to osteoarthritis and prescribed some NSAIDs with moderate improvement. We talked a little bit about NSAIDs and cardiovascular disease. But his psoriasis worsened, involving scalp, trunk, and extremities, now with 15% BSA. Let's remember that 1 palm equals 1% body surface area, so that's extensive coverage of his body, and he is referred to dermatology. Again, just in thinking of risk factors, I'll just mention again that the more extensive the psoriasis, the higher the risk of psoriatic arthritis.
I was just going to quickly mention, with regard to that severity, it's probably worth reminding folks that when he had that mild psoriasis, the topical may well make a lot of sense. Once he's gotten to the point of 15% body surface area, we probably do have to start a discussion, at least, with the patient about whether it's appropriate for them at that point to consider, continuing topicals. And I'm glad at that point it sounds like this primary doctor was ready to refer to dermatology. I think that's very much appropriate. If I remind people, if they were asked to apply sunscreen even to 15% of their body surface area twice a day for the rest of their life, for example, That can be pretty daunting, and then we have even the complications potentially of using chronic steroids in different areas of the skin. So it's probably not appropriate therapy for a lot of our patients with that much body surface area, and we should be starting to expand the discussion to potentially other modes of therapy at that point.
And I'd probably also just throw in, and we're going to talk about this more later, is that would have been nice too if the primary care physician thought that this was osteoarthritis but the patient had psoriasis, maybe just to check with a rheumatologist also to see exactly what was going on. All right, let's move on. Okay, so the dermatologist diagnoses the patient with psoriasis and psoriatic arthritis based on his morning stiffness, his asymmetric oligoarthritis, and his nail changes. And we're beginning to think about course of therapy. So before we even jump into that, we'll say that this is a patient with treatment-naive psoriatic arthritis. We want to think about how we go about deciding on treatment initiation. The ACR-NPF guidelines, as I mentioned earlier, would suggest that a TNF inhibitor would be the right initial therapy, but practically many insurance companies might require the use of methotrexate first, and there's just been a lot of controversy about methotrexate, the treatment of PSA. How do we square those ACR guidelines suggesting a TNF first with then the SEAM trial, which was published recently as well, which might suggest some greater efficacy for methotrexate than we previously thought? Joe, as someone who wrote an editorial on the SEAM trial, what are your thoughts about methotrexate in this situation? Is that something we should be thinking about first? Is that something we should be putting in the back burner?
Yeah, so there's a lot to unpack with that for this particular case. I'll start with the generic first, which is, SEAM PSA trial, just to spend 30 seconds, was really meant to ask the question of whether etanercept monotherapy versus combination therapy with methotrexate versus methotrexate alone, would be viable, and was there a difference essentially there, without going into too much detail. And what we learned is that in that particular case, that the combination therapy didn't seem to offer any additional benefit beyond the etanercept in that particular trial. But the eyebrow that was raised was, despite not having a placebo, we all said, these are pretty good numbers for methotrexate, and it seems to be not so bad in the psoriatic arthritis realm. And I think that's what you're referring to. Let me put my dermatology hat back on to answer your question, which is when we look at, for example, the number needed to treat to get people to a reasonable skin clearance like PASI 90, it's awfully high for methotrexate. And we need to treat something like 40 people to get one at PASI 90 or something like that. It's very, very high. And we have a variety of really highly effective treatment options for patients. At this point, with skin disease as severe as what we've heard from this gentleman. If you layer on top of that the fact that we've heard he enjoys a few beers at night, won't fault him for that. Has obesity and probably some fatty liver disease either there or coming, based on what Elaine described earlier in her module. I would be pretty reluctant to think about methotrexate for this particular individual, but I do think it hasn't left our toolbox. And I think certainly many of us reach for it and use it in a variety of scenarios.
Yeah, so as we know, in terms of peripheral versus axial, methotrexate really has little no role in people that have mainly axial disease. So I think this really brings up the GRAPPA treatment guidelines as well, which talks about the domain-driven strategies. So really you have to look back and say, okay, what is the predominant domain here that we're trying to treat? And I think sometimes bringing us back to that will help that algorithm. And, the ACR-NPF guidelines are really meant as the classic sort of active psoriatic arthritis patient. And so if the patient sort of deviates from that, then we also in our treatment options will deviate. So just as Joe has mentioned, what we think of, liver status and someone who enjoys some beer, and whether or not, we really need to push them with methotrexate when we have other options as well.
Yeah, and again, I just put in one more push for the co-management here as well. I mean, we hear that he has, an oligoarthritis, but does he actually also have enthesitis, which doesn't respond very well to methotrexate either? Sorting out the inflammatory back pain, I think, is important. So let's move on and see what he ended up on. So there are several choices. So his quantiferon gold assay test was negative. So of course we want to make sure that we do the appropriate screening in advance. Again, for comorbidities, he has a negative hepatitis B panel. And a decision was made to start adalimumab, really in psoriasis dosing, right? 80 milligrams at week 0, 40 milligrams at week 1, and then 40 milligrams every other week. His morning stiffness and oligoarthritis improves, and he feels less fatigued and more functional, something we see generally happen pretty quickly with TNF inhibition. So 3 months, though, his psoriatic arthritis is not bothering him, according to the dermatologist. And there was minimal improvement in his psoriasis, though he still has 15% body surface area. So really no improvement at all, and he desires some clearer skin. So psoriatic arthritis stable, but the psoriasis has remained unchanged. What would we consider next? So I think we're thinking here again about the ACR-NPF guidelines. The ACR-NPF guidelines would suggest potentially going to a different TNF inhibitor, but this person really didn't respond in terms of his skin at all to a TNF inhibitor. So the way I actually think about that frequently was this a primary or a secondary failure of the original agent? I think we would consider, at least for his skin, that this was a primary failure, that he did not respond at all. It's not that he responded and then lost improvement later on, which might suggest anti-adalimumab antibodies. So in a situation like that, we might want to go to a different agent. So let's move on and see where he went. The patient was switched from adalimumab to ustekinumab at 90 milligrams at week 0, 4, and every 3-month dosing. So that would be the recommended dose for his BMI and his weight. Within 2 months, his BSA decreased to 2%. But he develops a small effusion in his left knee and pain and swelling of his oligoarthritis, so he redevelops his polyarthritis. And 4 months after 3 doses of ustekinumab, psoriasis is 100% clear, but his psoriatic arthritis continues to worsen. So let's think about ustekinumab efficacy for arthritis. I might raise also that, first of all, that maybe ustekinumab not as good for arthritis as for the skin in comparative studies. We would say that we do like in obese patients to use weight-based dosing. Ustekinumab is one that is weight-based. But I would say a lot of us have some thoughts that maybe the actual dosing is a little bit low for the arthritis. Any thoughts about ustekinumab in this patient from either of you? Particularly also, again, thinking that he may have inflammatory spondylitis, although we haven't proven that yet.
Right. Well, I'll say, Evan, I'm going to let Elaine comment on the joint domains here. I think from a skin standpoint heading into this, having failed the TNF, I agree that as a primary failure, I like your approach there. I agree I would not have moved to another TNF. We have highly effective skin therapy in the sort of 3 arenas here if we're focused on the biologic, which would have been either an IL-17 mechanism or an IL-12/23 or a P19 IL-23 inhibitor. Those 3. And so I think as it turned out, his skin has done quite well. And I'll just put in a plug for the co-management piece, because this could be a scenario where I said, boy, your skin looks great. I've done my job, and go ahead and make your follow-up in 3 to 6 months at the front desk and give me a call, right? But tongue in cheek, of course, but then I would get on the horn to Elaine and say, Elaine, boy, I did a great job with his skin. But, he's complaining that his joints are still bugging him. He still has this low back pain. Can he wait 6 months to see you? He has an appointment with you in 6 months. Can he wait? Should he come in tomorrow? How do we co-manage this problem? And she would, inform me and educate me about, where we might head.
So it's interesting now, I think that we in the co-management world are, especially Joe and I, we're really encouraging people to have visits with the rheumatologist, visits with the dermatologist. So what you're obviously seeing here, at least what I think is really missing in this case, are lab work and imaging data, right? So these are what rheumatologists use as, does this gentleman have any poor prognostic factors, right? So we sort of glossed over that. And I think if you do have poor prognostic factors, you have to be a little bit more aggressive on the joint side. So I do that by seeing, so is the CRP elevated? Sometimes it's not, most of the times, but if it is, are there imaging damage already? Are there bony erosions? Are there changes already that I'm worried about on imaging? So with the poor prognostic factors, I think we can help answer those questions. So I do really, really encourage that co-management. So I have to say I'm finding more and more that when the dermatologists start the biologic DMARDs, they sort of skip us in the picture. And so we only see them when we have problems, and yet we don't have any baseline. So I don't know if you guys are experiencing that, but I think that's where that co-management message is important, because I think we would like to acknowledge those poor prognostic factors, look at their baseline. It's sort of harder when after they've gone through a couple biologics and they're like, oh, the joints are still active. Maybe we should have them see the rheumatologist at this point, which is then, 6 to 12 months later.
And even if it does happen at that point, Joe, I know you've spoken often about appropriate documentation and appropriate referrals. So if a patient like this who's been through a couple of agents already comes to the rheumatologist, it's important to know why those changes have already been made. What was the thought process behind that? Why did they have toxicity? Did they have lack of efficacy? Was it a primary or secondary failure? That way we can really move forward in a better fashion if there hasn't been real-time co-management.
Yes. Thank you for bringing that up. That's super important. And we've all had that moment where we revisit, well, maybe we should add methotrexate, and we've missed the documentation from the other provider that they've been there already, and they didn't tolerate it or it failed. And all of those bits in the shared decision.
Right. All right, so let's go on and see what happened. Again, worsening psoriatic arthritis. So the psoriasis is clear, but the psoriatic arthritis has worsened during ustekinumab therapy. So we're thinking about a need for a change to something else. So the patient is switched to secukinumab, and within 1 month, the psoriatic arthritis improves with a reduction of morning stiffness and less pain and swelling in his fingers. And after 2 months, his psoriasis is 100% clear, and the psoriatic arthritis was stable and under control. I always love that 100% clear. A PASI 100 is something that a number of years ago, Joe, I'm sure you can confirm that we never really thought was necessarily even attainable. But the interesting thing about this, too, is it doesn't tell us which dose of secukinumab, and I've been told recently that a lot of rheumatologists sort of feel like 150 milligrams is the appropriate dose for the psoriatic arthritis, which is what is approved for psoriatic arthritis. Again, particularly in heavier patients or patients with extensive psoriasis, I think the 300 milligram dose can be more effective. I suspect since a dermatologist was starting this, it probably would have been at 300. Any thoughts on that, or we'll move forward?
I'll echo your comment, Evan. I think I have my dermatology bias, but for me, almost all my patients start on the 300 milligram loading dose and move on.
So I sort of close this case with what I would call the glaring problem here, and that is the lack of co-management that we've touched on a number of times. We know that this patient had multiple swollen joints. Were they truly better when he said his joints were feeling better? He had low back pain. Was there spondylitis, as Elaine mentioned? We don't know what his sacroiliac joints look like. We don't know if he has syndesmophytes. Would we think about treatment differently if those were there? Was he really in remission from his psoriatic arthritis when he said he was feeling better? Did he achieve MDA? Did he achieve minimal disease activity, which is truly our goal to prevent future disability? So, really, what does co-management in a case like this look like? And I think we're going to use that to move forward into our next case and think about that just a little bit more. I will say that, as Dr. Marola said earlier, PSA is complicated. So let's look at this next case. 35-year-old female with a history of psoriasis since age 17, treated with topicals and phototherapy. 25, she develops oligoarthritis involving the right and left hand and the left knee, so 3 swollen, 4 tender joints. It's helpful to keep track of that. Enthesitis of her right Achilles insertion and dactylitis of one toe. She is also complaining of inflammatory type back pain, the type of pain that both Dr. Husney and I have discussed. She's treated with etanercept, 50 milligrams weekly with good results, and she does reach MDA, minimum disease activity. She's percolating along, but at age 33, she develops severe diarrhea, mucus-laden stools, colonoscopy positive for true inflammatory bowel disease. She's treated with tapering prednisone, enteric steroids. Etanercept at that time was continued. Now she presents with recurrent polyarthritis, now 5 swollen, 6 tender joints, so active disease, recurrent dactylitis, and back pain. Body surface area is 10%, so very active, with inverse psoriasis in the groin. Again, I find that a challenging diagnosis, inverse psoriasis versus fungal infections, especially in obese patients. A small papular lesion is noticed on her right forearm. And in her history, by the way, she smokes 1 pack a day for 15 years and has not been vaccinated against pneumonia or influenza. So let's look at a summary for this and say, well, what domains have been involved? She's got arthritis, she's got skin involvement, she's got enthesitis, dactylitis, maybe spondylitis, so she certainly meets the Caspar criteria for the diagnosis of and classification as having psoriatic arthritis. Her comorbidities, significant. She's got inflammatory bowel disease that has been active at times. She's a current smoker. And she's got this lesion on her forearm. Could that be a non-melanoma skin cancer? She's been on TNF inhibitors in the past. She's had prior phototherapy. And her prior systemic therapy has just been etanercept, a non-monoclonal TNF inhibitor. So I think there are a number of things that we can discuss here, and I really want to kind of focus on sort of derms and rheums working together on a case like this where things are just so complicated. So, what are some of the things the rheumatologist needs to think about? What are some of the things the dermatologist needs to think about, and how can we put that together? Maybe we can talk about the need for TNF inhibitor to address both her IBD and her PSA. Is that something we'd go forward with? And Joe, what does it look like for coordination of care here? How do you think a rheumatologist or a dermatologist should approach a case like this, especially if they don't have a combined clinic where the two docs can actually get in a room and hash this out together?
Yeah. Well, this is a very rich case, and I really love it because it brings up it's very real world. I mean, I feel like I'm sort of thrust back to my my clinic here, and I mean, this is Elaine mentioned a few minutes ago that she's been in situations where a drug was started, and then she's left with how do I now sort of pick up the pieces? How do I move on? Do I make a change? This is a perfect example of where I would have my own, thoughts and biases here about what would be maybe best for the skin disease, how it might be compatible with the IBD in joints and this non-melanoma or potential for non-melanoma skin cancer. To me, this would be a great point where we kind of hit the pause button. I would probably personally have a conversation with the patient, explaining what I think are some of the best options, having some discourse, explaining why. But saying maybe this is a case where they don't leave the office immediately with a prescription. I'll throw that out there. And it's not to withhold or hold up their therapy. But I might say, if I don't have a combined clinic with the rheumatologist right next door to knock on the door or pull them in, I might say, what, I'm going to refer you to Elaine. I'd like her to evaluate you as well. But, let me send her, an email, or let me, copy her on my note with my thoughts, and get back to you in, the next day or two about what we think collectively might be the best approach, and see whether she may want to see you even sooner than that 3-month visit that we have on the books. Maybe there's something that she and I can coordinate around this. Elaine may want some x-rays and some blood tests before we send you up to the lab today, to coordinate. And it seems simple and maybe even, overly simplified, frankly, but I think it really makes that patient feel cared for. I think we're doing the best thing, around coordinating for that care. And, and back to the case, we may have a discourse. Elaine may say, listen, the only way to go for this patient right now is an anti-TNF, maybe an infusion at our infusion center or something. How worried are you about this lesion on their arm? And I'll say, well, listen, you know what? I froze it. I'm not that worried. And we'll agree to screening, skin exams every 6 months for a year or two, in light of this, and really watch them carefully. I'm not saying that's the right answer for this case, but that's the kind of facilitated communication that we're talking about in getting the person to the right care, instead of a choppy thing where I say, hey, let's start a IL-17 today for their skin disease, and completely ignore the rest of this. And then in 3 months they get into Elaine and she says, what was Marola thinking? This is not the right treatment. Let's switch you again. And we've broken down that trust, where we're both trying to do the best thing for the patient, but the trust is worn, and we've given them 3 months of maybe not the best optimal care. So.
Elaine, what if you saw the patient first, and they had, this wasn't actually initially a dermatology case?
Yeah, I think I love that comment about hitting the pause button. I think putting the egos away and really saying, hey, I am not equipped to possibly judge this non-melanemic skin, rash condition, and I do need to, rely on my derm colleagues to tell me how serious they think this is. So I just love that pause button, and I think that requires some education with the patient, because they're coming to see you as a specialist, probably with an agenda to come out with a prescription and to clear all of this. So they need to be reset their agenda to say, hey, you have a couple things going on. This is not just about your skin or just about your joints or just about psoriatic arthritis and psoriasis. We do need to not only screen for the comorbidities, but understand how they are affecting, how serious they are. And then, of course, going back to imaging and labs, as I mentioned earlier, to help us really place where, the poor prognostic factors are. So I love that pause button. I love that pick up the phone and, leave those egos at the door and say, hey, this is what I think of the joints. This is what I found. What do you think about, your discipline? So I think that's important. So I would say I would do the same thing if the patient came to myself. I would hit the pause button and I would talk to my dermatologist and let the patient know. So I think many times we are rushed and we may not explain that to the patient. So I think co-management is, probably easier in our head, but also important to let the patient know what we're thinking.
Yeah, Elaine, I also love the idea of the pause button, but I also really want to make a push for real-time interaction, right? Because I think that truly this is a case that screams for two docs sort of looking at this patient at the same time and bouncing it around at the same time. And that way, truly then the patient would be able to walk out with a prescription perhaps at the end of that visit, if that sort of three-way meeting of the minds happens. And when I say three-way, it's the dermatologist, the rheumatologist, and the patient. And that's one of the beauties of that combined care model. Understandably, many people don't have that, although I would encourage it. And then what I've done when I'm not in my sort of rheum derm combined clinic is try to keep those means of communication wide open. So as you said, either pick up the phone. Sometimes that's not even easy to do because of our busy schedules. I have dermatologists who I actually text back and forth. I hate to say it, I sometimes say HIPAA be damned, but I'm going to send a text to my dermatologist who has also seen this patient and say, Mrs. Smith is here. The psoriasis is really flared up. Joints are bad. I'm thinking this. Is that okay with you? What do you think? And to be honest, I think in this new day and age where we're all doing telehealth, maybe even in the future, we're going to see some sort of telehealth visit that could happen in real time, in real life, where, again, there is that interaction between rheum, derm, and the patient to really make a decision in these complex cases where there are so many different options that could be chosen for the benefit of the patient. I've also found that when that happens in real time, that the patient buys into these therapies even more. You're going to get more compliance. You get better follow-up with patients that way. So again, I think this coordination of care is better for the patient and better medicine that happens over time.
So I do want to mention really quickly to the both of you and get your comments. We are seeing a large emergence of head-to-head trials now in psoriasis, psoriatic arthritis. Well, psoriasis, you've had a lot more head-to-heads than we have, but in psoriatic arthritis. So how does that maybe play a role and thinking about this, because I think the population that goes into these head-to-head trials are a little different in terms of how much skin, how much joints, and how we interpret it. So Joe, with your sort of dual hat.
Yeah. Oh, I get to wear both now. Fantastic. Well, lucky for me, this is a great case, to your point, Elaine, because I love head-to-head data. We need head-to-head data. I think in many respects, it also faces, though, payers and other groups when they do these sort of head-to-head, studies. And, here's a case in particular where we would need a third piece, right? This person with active IBD would never be included, or would be much less likely included in those studies. And so, we're dealt with we have, or at least we're provided these sort of polished and sort of pristine populations that enter a trial, and then we have the real world, right? We have the person who's a smoker with a, maybe PUVA exposure and active IBD, et cetera, et cetera. And so they serve their role and they're very helpful in our decision making. And then we're left with the real world, to both of your points, in terms of still needing to coordinate care and collaborate and figure out well. I may have wonderful data about a mechanism for their skin and joints, and still here I'm left with a black box around their active IBD and what's the right thing to do. So we're always going to have to learn from each other and coordinate in these more complex scenarios.
Right, I agree. Well, I think we're a little bit over time, and perhaps that's a perfect comment to wrap up on. And say that we really appreciate everybody's time and attention to this. We hope that we've raised issues both educational in terms of the disease process, understanding the comorbidities that we have to be so aware of, and also understanding the importance of co-management, really a focus of this to bring together specialties, to bring together rheumatology and dermatology, but also to bring together other specialties in the treatment of psoriatic disease. And I hope that all of those take-home points have landed appropriately. I want to really thank my colleagues, Dr. Elaine Husney and Dr. Joseph Marola, for the spirited discussion and for the really focused presentations. And we look forward to seeing you in one of our next programs. Thank you very much.